Forward. Good evening, everybody, and welcome to the Monday, July 12th edition of the Connected Kinesiologists Meetup. I'm Angela Pereira. I'm the founder of the Connected Kins group, together with Rebecca Adaman, my co-founder, who is a PhD student in knowledge translation for kinesiologists at McGill University in Montreal. I am the founder of First Line Education, a continuing education company for kinesiologists, and it's our mission to upscale kins so that they can really become as skilled and employed as they wish to be in the Canadian workplace. And one of the reasons we have these weekly meetups is a chance to network and get to know everybody, and also just to have a deep dive with different people in the industry and figure out how they got to where they did and what kind of questions you might have about our industry. So this evening we have with us JP Atwal, and I'm going to ask JP in a minute to introduce himself. I think what we'll do is move through the others that are here. You can have a chance to say hi, give us an idea of where you're from, and then we'll get started with JP. So I'm going to say hi, first of all, to Samantha Panton. Hello. I haven't actually seen you in person, I don't think, though we've talked a lot over the last couple years. So it's really nice to meet you. Hello. And can you give us an introduction of where you're coming from and what brought you to kinesiology?
Oh, well, I came to Canada for university in 2012, and I didn't know what I want. Well, I started in math and then ended up in kinesiology. Math was not for me.
Oh, wow.
Yeah. And then I worked as a kin in a clinic for 3 years. And after that, I switched over to some ergonomics, and now I'm doing disability management with some ergonomics on the side. So I work for a trucking company, and I handle all the disability claims, non-occupational and occupational.
Oh, interesting. And your accent is Caymanian?
I'm from Trinidad.
Trinidad. Oh, I was close. I was close.
Yeah.
I have a lot of relatives from Trinidad, Jamaica, and from Cayman. So I knew it was in that general area somewhere. Yeah. Very cool. Very cool. Well, welcome. Great to meet you.
Great to meet you.
I think next I will turn it over to, and I don't know your full name. I just know the name on the screen here, HD Tay.
Yeah, I'm not really sure how to change that.
Oh, okay. I can show you. I can show you the 3 dots on the corner of your own screen there. Click on that, and if you'll see rename.
Oh, on the image of myself. Okay.
Yes, there you go.
Sure. Okay, so as it will be revealed, my name is Hannah.
Hannah, hi Hannah.
Yes, I'm a kinesiologist. I recently got my first job in the industry. A couple weeks ago. I started last week my training. So it's kind of a lucrative, less glamorous job, but it's a start. So that's exciting. So I'm doing a lot of MBAs, and I'll be starting in my full-time position next week in Barrie.
Nice.
But I currently live in Markham.
Mm-hmm.
And yeah, I actually know Rebecca from Waterloo. I was doing my undergrad while she was doing her master's there.
Nice.
And yeah, so I'm just here to kind of explore different niches and see, meet other people and what their paths have been, just to get an idea of where I would like to go and how to get there.
Great. Welcome. Welcome. And Emma, you have a very glamorous backdrop this evening. I like it.
They're just some flowers, big flowers.
Just some flowers. They look beautiful.
Thank you. So I graduated kinesiology in 2018 from McGill.
So right now I'm working as a recreation programmer for a nonprofit here in Toronto for senior center. They do a Camp Sunshine on the Toronto Islands. So I'm just doing recreation programs for them. We're virtual this summer and last summer because of COVID, but we'll see how the summer pans out.
Oh, great. Yeah, that would be nice to be able to head over to the island, wouldn't it?
Yeah, we went there not last week, the week before. We went there just to like see what the island was like. Just the staff, no seniors, but yeah, it'd be nice.
Very nice. Very nice. That's great. And Zana, hello. Are you there? Maybe not.
Just hopping in and out.
Yeah, you're hopping in there. That's okay. We'll catch up with you. No problem at all. And Paul, finally, hello.
Hi.
Hi.
Can you hear me?
Yes, we can hear you just fine.
Okay.
Yeah. Do you want to say hi and tell us a little bit about where you are?
Changing devices.
Oh, no problem. There you are.
Hi, everybody. My name's Paul Atwal. I've been a kinesiologist since 2004. I did a couple years in active rehab. And then I've largely done some form of disability management ever since. Primarily, I have kept up with clinical work here and there. There's not much else to say other than I've worked in disability management is quite tough at times, I would say. You're required to learn really on the job. And you will be, unless you get a diploma of some sort where you get a couple of years of training. I have colleagues that have done that and they'd find it helpful, but I would say learning on the job is really how you will primarily figure out what to do. And the first person to train me in that industry at Manulife said it takes a minimum of 2 years to even become semi-competent. So
wow, that's about right, isn't it? For any, yeah, I would say at least
I found that to be pretty accurate.
Did you? Yeah.
So in a nutshell, that's me.
That's you. And I know you're out in Vancouver.
Yeah.
Whoops, I'm sorry. Client calling.
Yeah.
You're out in Vancouver, and did you go to school out west, or did you?
I went to UBC. I did a couple years of chemistry. Got a little bored and saw the writing on the wall for the environment of what I was studying. So
okay, interesting.
I'm like, I cannot be going into inorganic chemistry and feel good about it. So
oh wow.
Yeah, and so I actually took a year off. Was a dental career for a while. Just had a bit of fun. Bought a lot of vinyl. DJ'd.
Nice.
Yeah. And then started taking kinesiology courses and enjoyed it. And the rest is the history you already heard.
Yeah. And so you started with Manulife as you moved from active rehab into disability management?
Yeah, I did a 6-year temporary contract here, and then I actually went to Toronto for a couple of years. So got to experience the life out there. Came back here because I didn't really enjoy Toronto, no offense.
Choose between Toronto or Vancouver.
Yeah, and not everybody knows we're living in some trying times and what's happening next. Nobody really knows, but there will be work, and I think the skills needed in disability management, I've noticed, have always translated well from kinesiology because we have the scientific mind, and problem solving on the fly is a really big need because time is of the essence. You will feel immense pressure to get things done from everybody you connect with. Your management is driven by the accounting.
We're all driven by accounting.
Yeah, and they're counting the pennies, and so you generally will have a budget you're working with, and it's usually enough. But when you get those multiple conditions, it's usually not enough. And you will have to make some tough decisions of, in terms of telling somebody we're not able to fund rehab anymore.
Mm-hmm.
And you'll get coaching on how to do that, but it's not easy saying that. You're basically telling somebody they're permanently disabled.
Mm-hmm.
And what's kind of encouraging is the latest research is showing there's many conditions we thought are permanently disabled aren't anymore.
What kind of conditions would you say are among that group?
Yeah, a lot of these metabolic conditions,
Mm-hmm.
diabetes too, I'm seeing in clients, I hesitate to use the word cure, but their doctors are using it. So,
reverse, improve.
Reverse, remission. I don't really care what you call it. All I know is they're not on any medication anymore.
Mm-hmm.
And they're back to work, or feeling like they're not going to die anytime soon. So they're pretty excited. And a lot of these kind of issues that have sleep disturbances, you can use health coaching kind of practices to kind of get them going again. Mm-hmm. And what I found by working in disability management is the news flows pretty slowly into that field. So you really have to seek it out yourself. And I've always been that kind of person where you read studies, go to webinars, that sort of thing.
What kind of webinars and what kind of studies are you finding the most helpful for you?
The ones I've attended over the years have largely been focused on mental health and addictions. Mm-hmm. An area obviously that we don't get to study too much in school, but it became, over time, it just became the majority of the practice. If you had a case without any mental health issues, it was pretty, it might be 20% of your workload. So,
wow. So the other 80, you would say there's mental health.
Yeah, there's mental health components in there. Right. And you might not even know about it until later. You might get a referral that says this person fractured their, tibia 6 months ago, surgically repaired, they're ready for rehab. And, depending on the kind of job you get, you might be doing it remotely. In my opinion, not ideal, because you don't really see what's going on in the person's life. Mm-hmm. Doing home visits is really, I would say, important. So that's something you have to be willing to do sometimes in these roles. Not every employer does that, but it can be necessary.
Is that what you did when you were with Manulife? Like you were going into people's homes as well as into workplaces?
Yeah, you would usually start out by arranging a time to meet them at their home, if possible. Some people were not comfortable with that right away. Mm-hmm. And it can be for various reasons. So it wouldn't always happen, but I would say it would happen in 95% of the cases.
Where you start with them in their homes, yeah.
Yeah, usually you don't see anything too noteworthy in their home, but you might see, a lot of liquor bottles outside, mm-hmm. or a lot of mess inside. We're just kind of very cluttered home, hoarding type behaviors. I've seen that before. Mm-hmm. So,
or chaotic homes I've found occasionally where there's just lots going on, very, very noisy, very challenging environment for people to actually heal and recover.
Yeah. So like if you're well, you can possibly tolerate the noise of a subway, mm-hmm. But if you're not well, it's actually going to limit their healing. So because they're not going to be sleeping as well, and sleep disturbance becomes a bigger problem, then it's like, it's going to be a bad feedback cycle. So mm-hmm. they're usually not able to move for financial reasons, and just getting a move going when you're not well is not happening. So if you point out these barriers, sometimes you're laughed at, to be honest.
And who's doing the laughing in that case? Like
sometimes your own team, your own managers.
Team. Oh wow.
The insurance company.
Mm-hmm.
You're like, that's not our problem. I'm like, well, the whole situation is our problem, and we're here to solve it. So you will run into attitudes and stigma around some of these things. Mm-hmm. I've had some very challenging conversations over the years with case managers from insurance companies where, stigma comes in, judgment comes in, and it's like, it's really not helping solve the problem at hand.
Mm-hmm.
Why are we even having this conversation? And there are, ways to escalate the situation, usually to your manager, and they'll discuss with the other person's manager on what to do, but you usually end up wasting 2 to 4 weeks.
Oh, wow.
And then it's, well, we need to get a specialist assessment, and then you're looking at, 1 to 3 months to get that. And
there's
all
delays.
in the meanwhile, disability is being entrenched. So
Right.
and
So you were going in as a kinesiologist, as an assessor, or were you working on this from the case manager side?
Usually the case management side. I would have somebody do some basic, active ROM stuff.
Mm-hmm.
If that was a known issue, but it was usually a verbal interview and reviewing the medical information.
So you were the case manager? Sorry, you were the case manager, or you were the kinesiologist? You were the rehabilitation provider?
Yeah, the job titles you'll see in this field are like rehabilitation consultant, rehab specialist.
Right.
If you work at a large employer, it might be employee health related,
mm-hmm.
disability management consultant. Like there's different words out there. But in the end, you're kind of using the same skills. They might be more in the workplace, or they might be more on the road.
Mm-hmm.
But in the end, they're very similar. Just who is your main client? It could be the person's manager if you're a large employer,
mm-hmm.
Or it could be the insurance company that's kind of paying your salary. So.
Yeah, it's interesting, isn't it? It's a challenging conversation to have with a client, because you're explaining your role as a treatment provider. You're being paid by the group that's insuring that worker, and you're also communicating with the employer in many cases. So you have the employer, other rehabilitation providers, and also the insurance company representative. And so sometimes there's a union representative, sometimes there's also a lawyer or more involved.
Yeah.
So you're in this place where your place of assessment and treatment plan design. And Paul, what would you say? Would you say you would design typically a 12 to a 16-week plan for your insured, for the client?
Yeah, that would be typical. You usually don't see them much longer than that.
Mm-hmm.
And even though you might think it'll take longer, it's never going to really fly with the insurance company. They're always hoping to close it within a few months.
Mm-hmm. Mm-hmm.
When there's deeply entrenched, especially with mental health issues, you're probably looking at measuring things closer to years.
Right.
Especially if there's childhood kind of traumas, they're really not going to go away that fast.
Right. Yeah. It's a matter of sort of disclosing those things, acknowledging those things, reporting those things. So, and then figuring out whether that person does need a referral. So they would be out of our scope generally, but we would know to be able to refer to a psychotherapist, a psychologist, a psychiatrist, a social worker. So we would know then to be able to say, I'm seeing these red, orange flags. They'd be orange flags because they'd be mental health, to do with mental wellness. So that would definitely be something you'd need to state. And then they're so entrenched, as Paul was saying, with people's physical health, that then if we are tasked with making sure that people are on the road to physical wellness, how are we acknowledging that mental health piece, right?
Yeah, exactly.
Mm-hmm.
What I was seeing pretty recently is, depending on the organization you're working with, so I've worked with Canada Life, formerly Great West Life, a lot.
Mm-hmm.
And, depending on the case manager and their knowledge, they might quite easily be accepting of your recommendations.
Mm-hmm.
They might be challenging them, even if they came through specialists. Be like, oh, we don't need to pay for the yoga, for example, even though this person has, somatic symptoms.
Right.
And the psychologist that's working with them wants them to get, at least once a week, go to yoga.
Mm-hmm.
And there's, as we all probably know, you're not really dealing with motivated people. They're really stuck in their current behaviors.
Mm-hmm.
And there is a lot of financial barriers today as well.
Sure.
That, even that, $50 to $100 a month may not work for people,
Mm-hmm.
even though they're getting, some, significant amount of money, $2,000, $3,000, $4,000, depending on the insurance plan coverage.
Oh, you mean to pay for additional yoga classes?
Yeah, and group classes can work, but they don't work as well as one-on-one.
Sure.
Especially with an experienced, somebody who's got trauma-informed practices. So
right.
Like that is something I do offer one-on-one, and
Oh, interesting.
Yeah, I took some yoga training out here a few years ago. I'm like, this is basically ancient kinesiology was my my kind of was one of my thoughts. I'm like, it makes a lot of sense, and if we use the techniques of breath work and we use the right words,
mm-hmm.
you can release chronic pain out of people's body.
It's interesting when you do that somatic training, isn't it?
Yeah,
and
it is.
that awareness of the body, and it's pretty interesting to see what can happen.
Yeah, so it can be pretty powerful, and that's where I think, if you're not familiar with yoga or Tai Chi or similar things and why they work, I encourage you at least to watch some videos around trauma-informed care. And I like yoga because I'm Indian background, so to me it has
we
that
wouldn't
element.
Assume that, Paul.
Yeah, so but it can be a useful tool to bring in when you're seeing some of these things. And if you're just case managing, you can think about, should this be happening on your case, and finding the right people to make that happen. So
the wonderful thing about being a kin is that we can do all forms of movement. So we may do movements that some may call yogic movements. We may do breath work that some may also call work on the thoracic cavity. There's all kinds of ways of talking about what we do and working with our clients so that we're enriching that somatic experience that they're having. And I guess as we're working with clients, we're kind of judging, well, what are they comfortable with us calling it? What is the case manager comfortable with us calling it? Or a lawyer or an insurance representative or another colleague. So that may be part of what we decide to write in our treatment plan and in our reports, that, this may be called somatic therapy, but it's also breath awareness. It's also mindful movement, something like that, which, as Paul was saying, might be a helpful way of getting it approved as part of a treatment plan, whereas using different language may not be as widely accepted.
Yeah, and that's where, in that specific example, I didn't expect pushback from the insurance company case manager on that. I think it was honestly the word yoga. They probably had a impression of what was going to happen. So it is what it is.
That's interesting. Now, have you ever called a case manager or a lawyer kind of ahead of putting something in a report and kind of saying, so I'm drafting my report and I just wanted to chat with you for a minute about the recommendations that I'm thinking of putting into the treatment plan. Would you have a minute? And sometimes as you're talking with them, you can jot down words that they use, and you can realize ways of writing something that mean the same thing to you, to your client, but actually make the funder or the person who's advocating on your client's behalf more accepting. And I've found that to be a really good trick to do.
Yeah, I agree with that a lot. And it's, you know, when in this example I'm using, it's coming from a place where my caseload was actually way too high. It was probably two people's work.
Surprise. I've never heard that before in disability management.
Yeah. And it's one of the reasons I left that job. I'm like, this is not changing. I am burned out, and I'm going to go. So, you know, I left that work and took a bit of a break. And so, you know, now I do mostly contract work for a few different organizations, and I'm happier for it, but I'm not paid as much either. So, you know, there's always a yin and a yang to everything going on.
Yeah.
Right. So
disability management does seem to pay better in some cases than clinical rehabilitation, because you need such a huge range of skills. And
yeah,
it's not only the assessing and the treatment planning, but it's also the writing, and it's that long-term, how do I actually put something on paper that's 12 to 16 weeks long that is fluid but not too fluid, because I've got someone with a budget who's a penny counter who's watching the time tick down and the budget tick down, and am I able to achieve the goals that I set out to achieve with the client? So there's a little pressure there.
Yeah, there's a lot of introspective work required, and you know, you really have to develop great communication skills.
You do.
And it is a challenging role, but very rewarding as well. To see, you know, a plan work out, and it tends to work out most of the time, but it's, you know, sometimes you're just not fully aware of everybody's situation, and you can't solve all the problems in the world. You know, you'll run into barriers where there's a person's living situation with their family is very chaotic, and it's, you know, you hope it doesn't become a problem, but it usually does.
It's really challenging because sometimes it's the main earner who is working with this disability.
Yeah.
So, you know, we've all seen what it's like to have that main earner, you know, feel incapacitated, feel guilty, not being able to do what they used to be able to do. They're anxious about, will I get better? How long is it going to take? How am I showing up in the world? I'm not pulling my weight at work. I'm not pulling my weight at home. You know, and they're kind of just doing this on you. And you're thinking, okay, where do we start in a way that makes sense for this person? So how can I reassure them without knowing all the answers? But how can I give them some confidence that they have the self-efficacy to start to succeed on their own? Where do we start? What kind of things may work for them as we go through their history together?
Yeah, and that's always a tough one. It can get very challenging if the person's still working, in terms of time management. You know, I would sometimes recommend people actually go off work, but then they cannot absorb the financial impact of that.
Right.
Because, you know, somebody's salary drops 50% because they don't have any, you know, other coverage of any kind. It becomes pretty difficult to sell that to them. Even though from, you know, the planning standpoint, it might be the best option. So.
It's challenging because when I used to do a bit of this work, you'd have shift workers. So that worked because you could meet with them before they went into work. But I also did this kind of work on the weekends because people were at work. They may be underemployed. They're not doing their particular previous job demands. But on the weekends, particularly if they'd had a chance to sleep a little bit, maybe eat a little better, spend some time with family, by the time you saw them on a Saturday or a Sunday afternoon, you actually could get somewhere with them. Whereas if you were hitting them after work, before they'd eaten, after a long day, it's like meeting a different person than on a Sunday afternoon. So I also learned that if you're doing this kind of work, it's not necessarily an 8 to 6 sort of thing. And so you may need to think about, well, maybe for me, I work Saturdays and Sundays, and I work late afternoons as someone comes home from work. So that may happen so that you can keep someone at work during their regular hours.
Yeah, you might have some cases where that's a helpful strategy, and depending on where you work, it may be something to set up, or it may not even be possible.
Right, if you're working for someone whose hours are 8 to 4, yeah. If you're with another company.
Yeah, I did 10 years with the health authorities here, and
wow.
So that's 24/7 operation. So you could usually find time for most people to carve out some time, and because it's unionized, you could pay them to come see you also.
Oh, sure.
There was ways to make that happen, but not every employer is going to have that sort of a system.
Mm-hmm.
So each employer, each insurance kind of policies can be unique in what's actually possible to do.
So when you were doing this kind of work, were you party to the budget that you were given? I know you, or maybe I'm making an assumption here, when you were designing a treatment plan, did you put a dollar amount to that treatment plan? And did you understand, was there a negotiation, and did you understand what the final amount coming to you was, and you could spread that out through a number of weeks?
Yeah, usually in these roles, once you've kind of got your feet wet, you'll be given a kind of dollar amount cap to work with, and they trust you to work within that budget. And if you need more, the earlier the better. Is
yes.
Make that recommendation. It becomes pretty obvious after you've done a few more complicated ones. But again, nobody likes surprises in this business. And if you say there's a new diagnosis, people are like, what do you mean there's a new diagnosis?
It's week number 8. We've only got 4 weeks left. You can't show me something new.
Yeah, like on the insurance side, they're usually measured on claim closures and metric how long the claims are open. So they're thinking like that. And you might be thinking simply about getting the person well as soon as possible, not really thinking on the timelines of, your plan could be flexible.
It's a very, very good point. So like you were saying, if you were able to have that early conversation with a case manager, a case adjuster, to say, what are your objectives here? Yeah. So tell me what you need. And they'll say, case closure, under budget, and I need to see this person back doing these job demands. So if you can have that conversation to say, what do you need? So you're negotiating. Okay, well, here's what I need based on my initial assessment now. So let's talk about how we can make this happen, because you both essentially have the same client or claimant, but you both have competing interests, generally competing interests. So how then do you mesh this? And then I used to call the adjusters or the case managers every couple of weeks and say, hey, I'm just checking in. I know I'm not submitting a report yet, but I just wanted to let you know. And I'd often write into the treatment plan check-in call, 15 minutes or something like that, so that they knew I was going to be checking in with them and just letting them know how the last couple of weeks have gone. And to Paul's point, as far in advance as you know that you may need an extension, make sure you're mentioning and the reasons why, and you can show your progress to say we've just hit a wall, or there's been a change in the diagnosis, or we got a test result back, so this is going to change our approach a little bit, and here's what I'm thinking we're going to do it for our next steps.
Yeah, the more warning you give people, the more they can prepare for it. It's it's simple communication truth. It's,
Exactly.
part of sales, part of marketing. If you study those areas a bit, they kind of teach you these things.
Yeah,
it's our psychology. So
absolutely. Yeah, the old question, how can I help?
Yeah.
is really handy both for the people that are paying you and the clients that you're working with. And then
Definitely.
repeating that. So what I hear you saying is, and then it's easier to go forward from there. Yeah.
Definitely. Yeah.
When you're doing report writing, were you given a template from the insurer? Did you have your own? How did that part work for you?
It depends on the standards of where you work. Some places I worked had a formal template. Definitely useful when you're starting out.
Right.
As kind of a, you can space it out and take it as a assessment form. The more experience you get, the more I notice people would just take blank paper. I'm not a fan of that because I still prefer having my bases covered, especially with, biology doesn't change and the knowledge around health is updated, on a daily basis. And are you keeping up with that? So, I would add things to the form. So,
okay.
Over time, and it gets longer, but it's, mine's currently around 4 pages, I think.
For your initial assessment?
Yeah, when I'm doing,
that's not bad.
Yeah, I know there's longer ones, and I seek them out. I'm like, this is more for an acute care social worker.
Okay.
Like, I'm not quite that person, but I can see why asking some of these questions might be useful. It can be very detailed family history, what's happening in the house.
Right.
Depending on the place you work at, they just don't care sometimes what's going on in the house, unfortunately. And it's really it's unfortunate because you see these benefit plans where we have short-term and long-term disability coverage. And then over here, we have family assistance. And I'm like, what exactly are we doing here, right?
Yeah, can we refer them for some family assistance at the same time as they're on an STD claim?
Yeah, and usually you can, but then you're not really sure if it's actually happening. And in my experience, some of these employee assistance plans are not very good. They are more interested in having cheap counseling. It's sometimes not in person ever.
Oh, wow.
So, because of the work I did for the health authorities, I had to become an expert in the benefit plans of, the several unions you're usually working with. And, some of the health authorities here have a very external family assistance program, similar to like some of these bigger companies out there people might have heard of, whereas Vancouver Coastal Health does it internally. And they have very high standards of you must have been a therapist for at least 10 years.
Oh, wow.
To work in the program. So, and of course, then they're quite well paid as well. So the standards are quite higher. So depending on what you get, you might end up with a psychologist or very experienced registered counselor, or you might end up with somebody who's in their first year of practice. And you don't really know what you're getting, especially these programs. They're not allowed to issue any reports. And usually the client has no idea of the quality of counseling they're getting until, a few sessions or a month or two into it. And they might just have no idea what to expect, right? They've never done something like this. So
yeah.
So you might have to interview them on what services are you getting? Are you being asked to do any homework? Do you even like the counselor?
Right. Yeah, exactly. Is this working? Do you find it helpful? Yeah, that's right.
Yeah.
So do you see that just for the people here, are you familiar with the differences between short-term disability and long-term disability? So no, Paul, could you explain the difference between those two? Because they mean different kinds of benefits and services to the people who are categorized in those ways.
Yeah, short term generally means, a few months. It can be 2 months, 3 months, 4 months. I've seen up to 6 months in certain plans, and it tends to pay more than a long-term disability benefit. Again, it can, but not always. So
this is to the client, right?
Yeah, to the client. You can see anywhere from kind of 50% of salary up to 90%. It really depends. I've seen a wide variety of things. And same with long-term disability. You can, in unionized, well-paying roles, you can see, kind of 75%. And then in the kind of private employers where it's, you might see around 50% of your income is available through a benefit on long-term disability. And there's, again, everything. Long-term disability could be a 12-month benefit, or it could be 24 months or 18 months. Somewhere in that range is typical.
So that's as long as someone would receive the benefit. So short-term might be up to, you're saying 3 to 6 months, and then beyond the 6 month-ish, they'd move into long-term disability.
Yeah, exactly.
Right. I think in Ontario, we see short-term being almost up to 2 years, and then they shift into long-term at the 2-year mark. But as you were saying, that could vary according to employer and who the employer's insurer is. So who the employer is buying their long and short-term disability coverage from.
Yeah, it's usually the employer will decide what kind of coverage to get and offer the staff. And there's basically whatever you're willing to pay for, you can buy from an insurance company. So
yeah, so that's the other thing I was going to mention is for anyone negotiating and navigating their own job, ask about your benefit plans, because you can go through your benefit plan and you can negotiate each of those parts of the benefit plan. So you may be able to raise your short-term benefit allowance that's coming to you. You may be able to change the timeline and make that short-term benefit plan last a longer period of time, so you have greater money for a longer period of time before you flip into a long-term disability status, and then you can navigate that part as well. So sometimes the employer buys an off the shelf from the insurer and they say, this is the plan we bought, this is what you're going to get. But other times you can navigate and negotiate that, and it's worth a try to do that. And then as an insured, then as an employee who makes a claim, you want to make sure you understand what's in your plan, so that the employer is not just telling you, here's what we're going to do, but you can say, well, actually, I'm entitled to this according to what my policy says. So just making sure you know the paperwork. And that's hard for many employees to figure out. And that's a challenge too. And we're not in a position as therapists to go in and start looking at what their plan entitles them to. We're working with those case managers and case adjusters to figure out, okay, this is the parameters of what we're able to work within according to that employee's plan.
Yeah, each plan is different, and this is really where the insurance case manager is the person to ask usually.
Right.
But as you work in the field, you become more familiar with, well, this employer has that coverage and it hasn't changed in 5 years. And,
right.
It probably never will. And
yeah, exactly. And sometimes employers will turn to you to say, well, I'm renegotiating my plan next month. What do you suggest? Or when we renegotiate our plan,
Yeah.
How can we do this so that we can better care for our employees? Because we realized with this file, we fell short in these areas. And that's wonderful when you have a chance to look at that. And of course, we only know as much as we know, but we can say, typically, here's what we're looking at for soft tissue injury and what we're looking at for mental health support, to the amount that we can talk about that within our core competency. But we can see signs of anxiety, we can see signs of depression, and we can say, you know, we need to think about bringing in a mental health professional here, because here are some behaviors that we understand in that orange flag arena of cautions that we need to pay attention to.
Yeah, exactly. It's a really problem-solving role, and the more you work in it, the more you'll be able to recognize these orange, red flags.
Mm-hmm.
Eventually, you'll be able to pick up on them pretty quickly by asking the right questions. You've done enough seminars or training in various mental health topics.
Even the mental health first aid courses,
Yeah.
very, very helpful.
Yeah, exactly. It's a great one.
Mm-hmm. Yeah, that's a great one. Any questions from anyone first? I want to dive into a little bit of talking about some of the training that's available for disability management cases. Any questions coming up at all? No, not particularly. So I've never done any formal postgraduate training in any disability management. For me, it's just been like Paul's experience. It's just been working in the field, but there are many certifications and postgraduate diplomas now that can help you in particular roles. And many employers are going to be looking for particular kinds of training. Paul, do you know of any certifications that you see often that you think would be helpful?
The one I know, one I'm most familiar with, is the one offered by NIDMAR.
Okay.
The Certified Disability Management Professional.
Mm-hmm.
And they also have a return to work focused one. I don't remember the exact name of it. And this organization is located in British Columbia, so it's
okay.
I don't really know of another Canadian one myself. I don't. Is there one out there that you know of?
Well, I was just looking at a few, and I'm not well versed in this area, so we will get some help to help us with these ones. But I know that there's a range of certifications at Dalhousie for for disability management.
Yeah, I'm not familiar with what's out there, and if you really want to work more in the rehab kind of specialist consultant role, there are programs for that. And I think the Vocational Rehab Association and another one is not coming to mind right now.
Okay, so we'll see if we can put those together. I'll just put in the chat here the group from Dalhousie. And then NIDMAR is, you can look up these certifications through NIDMAR, and I will ask other colleagues of mine about what some of the other ones are, but sometimes you'll see them pop up in job ads, and then other times you can look for related qualifications. So in this area, we're not particularly talking about doing functional capacity evaluations, physical demands analyses, or post-offer pre-employment screens. We're talking about perhaps using those tools as they were completed by someone else, and using the recommendations from those reports and really working with perhaps the recommendations from those reports to alter the workplace and help that person in the work hardening and work conditioning process. So you can be an assessor that does what does the work site look like? What does the person look like? And is there a fit? And then you can work in the disability case management area where you're trying to help that person better fit. And then you could also work on the occupational health and safety side with the team to change the work environment and change the work station to better help that person fit. So you've got the assessor role, you have the disability management role, the ergonomics role. It's all very closely related, but they are kind of separate areas. Am I explaining that clearly, Paul? Is that making sense?
Yeah, that is correct. There's, 1 or 2 year programs to do there's health and safety, kind of occupational health and safety colleges, offering pretty short programs if that's an area of interest. There tends to be a lot of jobs for things like that out here in the mining sector and construction sector. So, and other kind of physical type jobs. The more medium and sedentary type workplaces usually have more of what is called disability management, as we're talking about. So,
right.
Yeah, so I'm more experienced on that side of things, whereas, in the healthcare sector, you got to deal with radiation and biological hazards.
Oh, fun.
Yeah, so I was familiar with it, but I'm not trained in that stuff. So yeah, so those colleagues I would work with who would handle that. So yeah.
Well, this is great. I really appreciate you helping us with this conversation, Paul, because now it helps to guide our next step, which is to look at we've had some chats about ergonomics in both industrial and office. Now we've had a discussion about disability management, what that looks like. And now we'll start to look at, well, what are some of the certifications? What are some of the continuing education credentials that could be helpful to complement your kinesiology degree and your kinesiology experience, such that you could move into some of these occupational health and safety disability management roles with success. So that's wonderful. Does anyone have any questions for Paul before we wrap up this evening? No, if you think of anything, let me know. And if anything comes to mind in terms of, I'd really like to know more about this part of the conversation, that would be great as well, because that way we can find others or bring Paul back to talk more particularly about those areas. Thanks, everybody.
Thank you all. Have a good evening.
Thanks, Paul.
Bye.
Bye for now.